Colleagues Zaire Bartholomew and Amaya Langine, and we're part of the Birth Equity Project, and this is our first event, and we are so excited to have you here with us tonight.
Thank you so much.
So we want to start by discussing the Birth Equity Project. This was made possible through funding from the Columbia University Social Justice Mini Grant Program, which is designed to promote discussion on the health disparities that exist for minority communities. So we are students from the Mailman School of Public Health, and it is our goal to educate the Columbia community and the wider community on the various inequities that take place for Black women during labor. And additionally, we hope to advocate for health equity by highlighting reproductive justice and birth equity efforts that seek to reaffirm and reestablish the role of community in the birthing process. And as future public health professionals, we hope to equip Mailman students and again, the overall community with the knowledge and capacities to take action to disrupt the overburden of adverse outcomes on vulnerable minority communities. So we're going to do a quick round of introductions. Again, my name is Paige Centino. I'm from New Orleans, Louisiana, and I am part of the Department of Health Policy and Management at the Mailman School of Public Health with a certificate in sexuality, sexual, and reproductive health.
Okay, go ahead. Go ahead, Amaya.
Hello, everyone. My name is Amaya Langine. I am in the Department of Health Policy and Management with a certificate in sexuality, and reproductive health.
Hi, everyone. My name is Zaire Bartholomew. I'm a second-year MPH student here at Mailman in the Population and Family Health Department with a certificate in SSRH. I'm from Atlanta, Georgia, by way of Brooklyn, New York.
So here's a quick overview of what we intend to cover in tonight's presentation. We're going to first start with legacies of slavery and looking at how the past influences our present. Next, we will be talking about Black birth workers over history, looking at the history of midwives in the United States and highlighting a few key figures that are often hidden in our history. Next, we will talk about the current state of maternal mortality. And finally, we will look ahead to the future by discussing reproductive justice, which will be joined by Professor Latanya Mapp Frett.
Alrighty, and so it's on to me. So I just want to thank everyone again for taking the time to come out and speak with us today. And so I get the honor of kicking off our presentation and really grounding us before we move forward with the rest of the slides. And so before I begin, I want to acknowledge that what I will be presenting today is sensitive and can be very emotionally heavy on the spirit and the mental. And so we encourage you to take care of yourself, however that may look like, whether it be logging off, enjoying at a different time, turning off your camera, or just giving yourself a moment of silence before we begin and continue on throughout our presentation. Next slide, please. And so before we begin, I want to start off with what is called a Sankofa moment. So literally meaning going back and fetching it. And so I was introduced to the Sankofa moment being put into reproductive justice during one of my classes by a guest lecturer, the amazing Dazon Dixon Diallo. And so Sankofa is an African word from the Ankh tribe in Ghana with the literal translation of, it's not taboo to fetch what is at risk of being left behind. And so with the implication that knowledge of the past must never be forgotten. And I love how the Resilient Sisterhood Project speaks to Sankofa. They really emphasize, if it happened, if it was accomplished, it deserves to be told. And so I want to frame our entire conversation around going back and giving honor and reverence to the many leaders and waymakers of this movement. And if we are to look ahead and to reimagine what healthcare will look like, being accepting and equitable for all, we must know the entire story and the entire history. And that requires us to reach back, assess, and continue to march forward. Next slide, please. And so I want to start off and frame our conversation with the story and the journey of Anarcha, Betty, and Lucy. And before I dive in, I want to make it clear that these three women were most likely not the first women to have such heinous and horrendous acts committed on them. But I chose to start here because their story signifies a turning point in medical discovery around women's reproductive health and maternal health. And so Anarcha, Betty, and Lucy were three enslaved women who lived and worked on different plantations near Montgomery, Alabama in the 1840s. And all three women all three women developed medical conditions after childbirth that caused them to lose function of their bladder and their bowels. And because of such condition, they were kept away from other workers during the time. And so because there was no cure, Anarcha, Betty, and Lucy were told that they would have to live with this pain and shame for the rest of their lives. And so another key figure in this story is a physician named J. Marion Sims. And like many others during the time, he was really interested in medical advancements and experimentation. And so he made arrangements, with the enslavers of Anarcha, Betty, and Lucy to lease them to him during their treatment. So the idea was he was going to perform different experimentations and procedures to see if he could cure them of their ailments. And so during this time, he would have complete control over their bodies. And it was really unlikely that Betty, Anarcha, or Lucy ever had the opportunity to consent to the experimentation that was going to be done on them. And so another point that I really want to emphasize is that during this experimentation and these procedures, Sim did not use anesthesia to numb their pain at all. And this was partly because during this time, doctors felt that doctors feared that their patients could die from anesthesia, but it was more so because these physicians believed that Black women's pain tolerance and their skin was thicker and higher than white women. And so during Anarcha, Betty, and Lucy's surgeries and during this experimentation, they were very conscious, aware, and in their skin and being able to realize and feel what was being done to them. And so it turns out that all experiments and all procedures done on all three women had failed. And so because of this failure, the medical physicians during this time had deemed Sims to be a failure, casting him out of society, telling him that, you tried these things, it didn't work, and so you should just stop, move on. And so because of this shame and casting out, we would think Sims to kind of retreat and think about, okay, well, maybe I'll do something else. Maybe this isn't my field or my lane. But instead, Sims continued to do these procedures on Anarcha, Betty, and Lucy and 12 other enslaved women for about the next 5 years. And so going back to the idea that he was cast out and shunned and it was a failure, his medical team and his medical staff around him quit. And so it was really him just performing these procedures. And so because of this, Sims thought to teach Anarcha, Betty, and Lucy of how to care for each other and treat each other after these procedures. And so after this 5-year span and 5-year term, Anarcha, Betty, and Lucy were professional medical providers. And it turns out that one of Sims' procedures did work and he did find success. And because of this, he decided to leave the South and return back to the North. And so around 1852, Sims published an article that outlined his new procedure. And to appeal to a wider audience, he decided not to mention that his operations were performed on enslaved women or that they had no control over their bodies. And so he also never mentioned that Anarcha, Betty, and Lucy during this time and after this time became professional medical practitioners. And so it's important to note that in the illustrations that accompanied this publication, it was shown that Sims was operating on a white woman with the help of white staff and white nurses. And so in this illustration as well, the patient is covered up. And so really a token of respect that Anarcha, Betty, or Lucy never got the ability or was afforded during this time. And so during this history and during me giving, a little bit of background about the journey of Anarcha, Betty, and Lucy, there are a few key things that I want us to pay attention to. And so that's the words of using least and having no control over their body, and especially the part where Sims decided to use in his illustrations a white woman being the test subject and a white nurse accompanying him, when this was far from the truth. And so looking back at the picture I decided to use on the presentation slide, I wanted to use this picture because when I first was introduced to the journey and story of Anarcha, Betty, and Lucy, it accompanied an illustration that showed an African-American woman on a medical table surrounded by 3 or 4 white males, white physicians. And so I really wanted to restore honor and restore reverence and rename and reframe the story as the mothers of gynecology rather than J. Marion Sims being known as the father of gynecology, because it is in fact through their efforts that we were able to have these medical advancements within women's reproductive health and maternal health. And so the artist that you see here with the sculptures, Michelle Brower, created these beautiful sculptures in Montgomery, Alabama. And she was also able to procure the land that these experimentations and procedures were done on and to Anarcha, Betty, and Lucy, and with the hopes of turning it into a Mothers of Gynecology Health and Wellness Clinic. Next, please. Thank you. And so on this side, I just want to talk about what became quote unquote true of the Black female body, and in essence, the mistruths of what the Black female body is and had become during this time. And so looking at the journey and story of Anarcha, Betty, and Lucy, it is clear that the idea of especially bodily autonomy, you don't have control over your body, but I do, and I can do what I please to do with your body and experiment on and in essence just rob you of what is naturally your human right. And so we thought about a few mistruths that we have seen throughout our time here at Mailman and in our education prior to Mailman. So some of them include quotes and just a few things that we wanted to really emphasize in our presentation. And so the first one, Black women have long had to operate through survivorship and resistance. The idea and the erasure of silencing of the Black woman, the exploitation of the Black female body, the absence of body autonomy, and Black women today can falsely be labeled as hyperfertile, and lastly, the strong Black woman trope. And so I want us to pay attention or remember these mistruths as I continue to go throughout and talk about different journeys and different stories throughout history, because it really lays the groundwork and foundation of being able to see why we see so much disparity within maternal and child health, and especially among Black women. Next slide, please. Okay, so the Ralph sisters, one of my favorite journeys, a part of my presentation. And so I sadly and gladly had the opportunity to learn about the Ralph sisters this semester during one of my courses through the book Take My Hand by Dolene Perkins Valdez. And I'm sad because I'm just a little torn as to why it was just now in my education journey that I'm hearing about the Ralph sisters. And I'll go into that a little bit more. But before I give a talk about the Ralph sisters, I want to play this quick 2-minute video just to give you all the background, the history, and the journey of who the Ralph sisters are and what they mean to this movement.
On June 27, 1973, a lawsuit was filed that brought national attention to the issue of racially targeted sterilization abuse. In the late 1960s and into the 70s, civil rights activists noticed a widespread trend among women of color. It was sterilization. In June of '73, the Ralph sisters, 14-year-old Minnie Lee and 12-year-old Mary Alice, who was mentally disabled, were sterilized without their knowledge or consent. These African-American girls had the procedure done at a Montgomery, Alabama family planning clinic that received federal funds. Clinic workers deceived the girl's illiterate mother into believing that she was consenting to the girls getting birth control shots. 2 years earlier, the Ralph sisters had been given birth control injections as part of an experimental trial, again, without their consent. After the federal government ended that trial, the clinic nurses decided that the girls should be sterilized. The girls were targeted for sterilization because they were poor, Black, and living in public housing. After the procedure, the girls revealed to their parents that instead of receiving shots, they had undergone surgery. On June 27th, with the assistance of the Southern Poverty Law Center, the Ralph family sued the clinic and the Office of Economic Opportunity, which provided it with federal funding. The district court found an estimated 100,000 to 150,000 poor people were sterilized annually under federally funded programs. The lawsuit led to the requirement that doctors obtain informed consent before performing sterilization procedures.
Thank you, Amaya. I'll just wait until we could. Okay, perfect. So when thinking about the Ralph sisters and thinking about the mistruths that I spoke about earlier, it's clear to see the complete violation of their bodily autonomy. And so thinking about 14-year-old girls having to go through such a life-changing procedure without knowing, one, what's going on to them, two, being asked or even given information about what they would be doing and what they would be undergoing. And so the act of forced sterilization and sterilization known as an operation that stops someone from ever having babies. So for example, hysterectomies, the idea that these two young girls were not given the opportunity to, one, understand what's going on and going to be happening to them, but also the silencing and the erasure of who they are as individuals. And I say that because the Ralph sisters, their journey, and the Tuskegee experiment also happened around the same time. And so for me personally, I'll speak on my end, when I in my past education, especially within my pre-med studies and then, gender studies, history studies, it's always talked about the Tuskegee experiment in the harmful things that were done to the Black women the Black men that were a part of those experimentation trials. But in my education, we've never talked about the Ralph sisters, and we never talked about the disrespect, disregard, and complete abuse and violence committed unto these young girls, and how they both go hand in hand in using and identifying that there must be informed consent. And so when we think about ableism and socioeconomic standing, you think about, the bodily autonomy of certain Black women being cut down even further. And so for the Ralph sisters, being disabled, being poor, and of course, being Black women, the odds were definitely and really stacked against them. Next slide, please. Thank you. And so now on to Henrietta Lacks. I'm sure many of you know, but if you don't know, just a quick history. So Henrietta Lacks died of cervical cancer in 1951 at the age of 31. And so surgeons at Johns Hopkins harvested her cells from a tumor they removed from her without her permission and without her knowledge or her family's knowledge. And so these cells became the basis for the first immortal human cell line, known as HeLa cells. So HE standing for Henrietta and LA standing for Lacks. And so variations of HeLa cells were used in research all around the world, resulting in more than 80,000 different discoveries in scientific publications, breakthroughs in things such as cancer research, as well as health benefits. But it also brought in an enormous economic return and economic return and benefit to biotech companies as well as pharmaceutical companies. And so thinking about the strong Black woman trope and how often it's said that, especially within the realm of politics, how Black women are so strong, they're going to save us from whatever we're going through if we listen to them, this and the third. And so in Henrietta Lacks' case, she is a strong woman. She did save the world and her cells helped save the world. But it wasn't until the beginning of the 1970s when her story became to be publicized, or any act of recognition to her and her involuntary donation to science was made public. And so again, looking at the silencing and the erasure of Black women and how we're not going to ask, we're not going to ask you or even inform you of what we're going to do, but we're going to take and we're going to do how we see fit. Next slide, please. Thank you. And so the last slide that I will be talking about is the Flexner Report. And this is completely different from any of the journeys that I took us through before. And I felt that it was really important to include the Flexner Report because, coupled with the mistruths and how they have laid a foundational backing onto what we are seeing within medicine, especially towards Black women, and the Flexner's report in its publication and how it led to the reduction of African-American physicians in the United States, both combined together, give us a little bit more understanding and framing of framing around what is going on between maternal mortality and why we're seeing what we're seeing today. And so the Flexner Report really is the landmark study that forced all about 2 Black medical schools to close. And a quote from Howard University's president, Wayne Frederick: "The Flexner Report was a catalyst. It started us down a road that is very hard to undo." And so some history behind the Flexner Report. Abraham Flexner was asked to study medical education in the United States and Canada by the Carnegie Foundation to help standardize medicine and medical education. So what we were seeing was a lot of different medical schools in the United States and Canada having different curriculums. And so once individuals are graduating from these institutions, some physicians would have knowledge of this, but not knowledge of that. And so the Carnegie Foundation really wanted to help streamline and find a way to make sure that once we were graduating physicians and once they were getting into the field, they were well-versed on these array of topics. And so in Flexner's report, he wrote that African-American physicians should be trained in hygiene rather than surgery and should primarily serve as sanitarians whose purpose was protecting whites from common diseases like tuberculosis. And so because of these quotes and because of the publication of this report, of and around 14 Black medical schools that existed, only 2 survived, which were Howard and Meharry. And so this led to the reduction and decrease in Black physicians that could serve their communities. And so some reports during this time really outlined and gave light to, depending on different states, there was about one Black physician for every 3,000 Black residents. And so we can imagine the stark reality between one physician and 3,000 patients when we see today one physician is overworked with maybe 15, 20 to 25 patients. And so why do I include the reflection report as part of my presentation? And it's because when we think about solutions and how can we solve the issues that we're seeing within maternal mortality, we think about increasing the number of Black physicians that are coupled with Black clients and patients, and how that can lead to the reduction of infant mortality and high infant mortality rates and high maternal mortality rates. But if we don't focus on the idea and see the whole picture and understand that we can't just think about producing Black physicians today without understanding that we've had a 100+ year pause and stop in the production and graduation into the medical school of African-American physicians. And so I really want us to take what the Flexion Report did along with the mistruths and really see how blended together they've caused the foundation of a system that is really designed to be set up against Black women. And so I implore you all to please join us in our next event next Monday, because we'll be hearing from OBs, midwives, and doulas about what they're seeing within the clinical space and how can we use policy, community activism in different ways to shake things up and reimagine what we want to see in healthcare. And so now I will pass it on to my colleague, Paige.
Thank you so much, Zaire. It is really key to establish this foundation, because to understand where we are in our current moment, we must understand where we once were. So in this part of tonight's presentation, I will be highlighting the history of Black birth workers to amplify the continued, yet often under-discussed contributions of Black women to improving maternal health outcomes. For definition, birth workers refer to those who support birthing people at any stage of the parental journey, not just labor and delivery, but this is typically consisted of traditionally midwives and doulas more presently. So though midwifery is predominantly occupied by white women in the United States today, this was not always the case. Granny midwives refer to the highly respected African-American midwives in Southern communities who provided care to the poor and rural. Midwifery was a deeply traditional and familial profession, as knowledge would be passed down from generation to generation. During the slave trade, African midwives were highly sought out and valued for their robust knowledge and the resources that they could provide, not only to other enslaved women, but to the families of slave owners as well. And though enslaved women were encouraged to have as many children as quickly as possible, midwives were subversive and subverted the capitalist system by aiding enslaved women in ending their pregnancies or timing them in a way that was more beneficial to their health and not the bottom line of slave owners. Yet post-emancipation, granny midwives continued to provide a number of services for their community in addition to caring for infants, such as being spiritual leaders, herbalists, nutritionists, lactation consultants, and counselors. So I first want to start by highlighting the contributions of Bridget, or Biddy Mason. Biddy Mason is a well-known midwife. Born enslaved in Georgia, once the family that had enslaved her settled in California, she successfully filed a petition that restored freedom to her and 13 of her extended family members. Once a free woman, she started the First Methodist Church in Los Angeles in 1853, which still exists today. Using the money that she earned from her practice, Biddy really invested in her community and was a well-known philanthropist. She visited the incarcerated, fed and housed low-income individuals, and eventually founded an elementary school. And Biddy's story really exemplifies how midwives were the foundation of their communities and helped those around them in a number of ways beyond merely delivering babies. Before the growing interest of physicians participating in labor and delivery, physicians looked down on midwives as uneducated women and often did so in racialized terms. However, at the turn of the 20th century, things shifted and white male physicians began attending births. This move is also associated with the devaluing of birth, moving away from birth as a highly sacred communal ceremony to a physical act that must be controlled. In 1915, prominent obstetrician Dr. Joseph DeLee was quoted as saying pregnancy and childbirth were dangerous and evil and should be subdued by the popular interventions at the time, which were forceps, sedatives, and ether. Instead of intervening when things went wrong, like midwives did, now all in labor would be subject to continuous observation and interventions in a preventative effort to keep any issues from arising at all. Due to the lack of experience that male physicians had with delivering babies, women were subject to experimental procedures and poor health outcomes skyrocketed. And as a result, regulations were passed on all birth workers, including midwives, even though that they had better outcomes than the physicians. The most prominent act is the 1920 Shepard-Towner Act, which required regulation and licensure for midwives. And these licenses would be granted to the predominantly Black female midwives by white male physicians based on their standard. Due to this law, there was a systemic belittling of the midwifery profession by those who could not grasp the immense contributions that these women made in their communities. Again, the same obstetrician that I quoted earlier, Joseph DeLee, is quoted as saying that midwives were a relic of barbarism instead of what they truly were, who were a vibrant source of community within those that they served. Next slide, please. So ultimately, the push to force midwives out of the labor and delivery space proved successful. In 1900, over half of births were attended by a midwife, yet only 35 years later, less than 15% of births were attended by a midwife. And today, that number is less than 10%. While most of the country adapted to the new medical model of birth, African-American women preserved the tradition of midwifery and continued to provide care when they were unable to receive care from segregated hospitals during Jim Crow. Margaret Charles Smith is another midwife I'd like to highlight tonight, and she had an early introduction to midwifery. At the age of 5 years old, she was present for a family member's birth, and Margaret was actually the one who caught the baby once it was delivered. This moment was a defining one for her and was the start of her midwifery journey. After the new regulations were put in place for midwives that I mentioned previously, Margaret was one of the first midwives licensed to provide care in Greene County, Alabama. This was the start of what would prove to be an illustrious career, birthing over 3,000 babies with very minimal mortality rates, as it was rare for an infant or mother in Margaret's care to die from complications, even though these were women who lived in the poorest of conditions. Twins, breech babies, premature babies, Margaret saw it all and delivered healthy babies each time without relying on the medical interventions. Again, during the time of Jim Crow, Margaret provided health resources to her community where resources and access to care was limited. And though Alabama outlawed traditional midwifery in 1976, Margaret was able to continue her practice due to her robust experience and years of work. In 1996, she authored a book on her experience as a midwife in Alabama called Listen to Me Good, the story of an Alabama midwife. Finally, the last midwife I would like to highlight tonight is Mary Frances Hill Coley. Mrs. Coley believed that midwifery was her spiritual calling, and she also delivered thousands of babies, Black and white, in Georgia during Jim Crow. And this was unique because at the time, Black midwives typically did not deliver white babies if there was a white midwife or physician present, or vice versa, due to segregation. But Mary Coley cared for all children equally, even if sometimes those babies' parents held negative beliefs towards her simply due to the color of her skin. She impacted the lives of thousands, and she was the subject of the 1953 documentary, All My Babies. This documentary highlighted Mrs. Coley's practice and exemplified the extreme care that she took in her work and the families that she served. And ultimately, this documentary was used as a training guide for other midwives across the United States. Next slide. So here's a short video featuring babies that she's birthed and members of her families and friends to really highlight the immense work and contribution that she made.
She was my neighbor, she was our friend, and when I got pregnant with Jesse, the first thing crossed my mind to do was get Miss Coley to deliver my baby.
She would come in the morning time and bathe that baby and give me a bath. And if I hadn't ate that morning, we had a wood stove. She'd go in there and make that fire and fix my breakfast. She was just really a very fine lady.
I want you to meet Mrs. Mary Cooley, a midwife who lives in Albany, Georgia. This is a story of how she helps people.
Mary Frances Hill was born August 15, 1900, in Baker County, Georgia. She was the youngest child and the surviving twin of Martha, who died at birth. Her aunts and uncles raised her after she lost her parents at a very young age. She married carpenter Ashley Coley and moved her family to Albany in 1930. It was after this move that she became interested in midwifery and was trained by Alabama midwife Annie Lee Logan in the apprentice tradition.
She delivered babies all around the area, about 3,000 plus babies. I'm one of those babies, by the way.
Over 30 years, Mary Coley delivered more than 3,000 babies in Dougherty, Lee, Mitchell, and Worth counties. She was known for her tireless work ethic and her willingness to serve both black and white mothers in the segregated South.
The racial attitudes in Georgia, in this part of Georgia now, are much different than they were even 25 years ago. When I first went to nursing school over 40 years ago, white physicians did not deliver black babies as a general rule, and black physicians didn't deliver white babies if the other physician were available.
She didn't care if I was white or if I was black or whatever. She was doing just as much for me as she would have been if it had been a black lady. Didn't matter to her, and it did not matter to me.
I guess you could call it a trade to learn. The blacks in this area were not really welcome in a hospital setting, and they weren't refused, but they were not welcome. So there were a lot of midwives, and they did an excellent job. They went out and delivered babies door to door, so to speak.
This is something that black women, of course, before it became professionalized and before medical departments got involved in it, black women were delivering black babies for millennia.
And such a scary.
And what I love about this video is the first person who was featured is she was not directly referred to as the midwife. She was the friend and the neighbor. I don't know about you all. When I have my doctor, I have my doctor. I don't call them my friend. And I think this video really exemplifies how deeply she touched the lives of those around her and just the joy that she brought to her community and frankly, the legacy that she's left on this earth. Next slide, please. So despite the overwhelming contributions that Black women made in the midwifery field, the trend against midwifery continued, and today a majority of births take place in the hospital. And over time, though the medicalization of childbirth led to reduced maternal mortality rates, a trend that is currently reversing and will be discussed later tonight, the over-medicalization of labor caused concern, as many began to question the necessity for interventions such as forceps, continuous monitored labor where you're unable to get up and move around, or the use of drugs to speed up labor. So starting in the 1970s, the home birth movement really took hold. And though at the time, the main participants tended to be white middle-class women, the demographics of the home birth movement have changed in recent years, especially with COVID, as more people of color and lower income individuals have moved to home births out of a desire to be removed from the hospital setting and to reintroduce the sacred nature of birth by calling back to traditional practices. And also in tandem with the home birth movement, doulas have been repopularized within the birthing sphere. I'm not sure if you're not familiar, there are several types of doulas, including abortion doulas and death doulas, but tonight I'm going to be focusing on birth doulas. Doulas are non-clinical birth workers who, like the midwives of the past, hold really multifaceted roles. These include teaching and education, being an advocate during labor and delivery, offering physical, spiritual, and emotional support to the family, and acting as a consultant at all stages of the parental journey, from prenatal care to postpartum care. Doulas are associated with positive birth outcomes. Studies have shown that doula-attended births have lower risk for cesareans, a reduced need for medical interventions such as Pitocin, a drug used to induce labor, and doula-attended births tend to have infants with higher birth weights. There's also a particular subset of doulas referred to as community-based doulas that are doulas of color who best represent the communities that they serve. They also function similarly to granny midwives in that their work is deeply based in commitment to serve the community in all aspects. Parents of all races have increased their interest in having a doula-attended birth as their presence in the labor and delivery space has risen in recent years. Birth workers over time have continually went above and beyond to provide families with the best care possible, even in circumstances where there wasn't much to give. Ensuring that we can increase access to midwives and doulas to those who are seeking these services is paramount. This marks the end of my portion of the evening, and I will now pass things over to Amaya to discuss the current state of Black maternal health in the United States.
Thank you so much, Paige and Zaire, for just setting the foundation, for Zaire for setting the foundation of what we've seen with the disregard for the Black female body, and Paige for giving us a historical context on what it looks like for Black birth workers doing work in the United States. So now I'll be routing us in the direction of the current state of maternal mortality today. So for starters, I just wanted to share a definition with you all on how the US defines maternal mortality rates. And so a lot of the information that we see comes from the CDC, and the CDC uses information from the World Health Organization to define maternal mortality and maternal deaths. And so the World Health Organization defines maternal deaths as any death that occurs during childbirth or during the pregnancy, or 42 days post determination of a pregnancy or after labor is complete. And these deaths need to be related to pregnancy-related deaths. Unfortunately, this definition does not include any pregnancy or women that have died due to deaths that may be related to car accidents, for example, which they identify those as accidental or incidental deaths. Additionally, I wanted to note that this definition leaves out the fact that there is a wide span of other ways that women can die during birth. And also this short period of 42 days does not encompass the year postpartum that women can die due to pregnancy-related causes. And so I think it's imperative when we're thinking about restructuring what maternal health outcomes look like for Black women, it may start with redefining what maternal deaths are defined as. And so as I have on the screen, I wanted to share with you all a statistic of the US maternal mortality rate in as it stands now. So as of 2021, there were 32.9 deaths per every 100,000 live births in the US. And so now shifting over into what specific state in the US has the worst maternal mortality rate, and that state is unfortunately Louisiana. Louisiana has the highest maternal mortality rate at a whopping 58.1 deaths per every 100,000 live births. So why is this number significant? I want to start off by just letting you know that 1/3 of the Louisiana population identifies as Black. Now, with that being said, I also want to share a quote with you from one of Louisiana State's senators, Bill Cassidy. He stated, and I quote, "About 1/3 of our population is African American. African Americans have a higher incidence of maternal mortality. So if you correct our population for race, we're not as much of an outlier as it would otherwise appear." In this statement, Bill Cassidy is not only denying the maternal health crisis in the United States, but he is ignoring the damage that racist systems such as medical racism as well as obstetric violence have perpetuated on Black women. And this has in turn caused the death of Black women during, before, and after childbirth. Now, as this presentation is talking about Black women and the Black maternal mortality crisis, I wanted to share with you a statistic. And so as of 2021, the United States maternal mortality rate for Black women in the United States was an alarming 69.9 deaths for every 100,000 live births. I just want us to sit with that for a moment. I gave you the statistics of the US maternal mortality rate, that in Louisiana, and here is just the US maternal mortality rate for Black women. So now, why is this in particularly an issue? This is an issue because we see that regardless of education, income status, or where these women live, Black women are dying during childbirth and due to childbirth-related issues. This is not to say that less well-off Black women deserve less care or worse care. If any, they need and they deserve more resources and great care. But it is to say that there's an issue with medical racism and racism overall for Black women in this country, which is causing a substantial amount of deaths in what is supposed to be a natural and fulfilling process, bringing life into the world. And so here I wanted to just provide you all with some statistics over the last 4-ish years from 2018 to 2021. And for those that don't know why we're not seeing 2022 data, as the year goes on, once we start a new year, the previous year, they take time to synthesize and analyze that data before it can be presented to the public. And so that's why we have 2018 to 2021. As you can see, across the board, between 2018 and 2021, Black women are dying substantially more than any of their ethnic and racial counterparts. And we see that across the board, the maternal mortality crisis is increasing and the maternal mortality rate is increasing substantially. So let's put this into context of why this is a greater issue overall. So the United States uses over 18% of its gross domestic product, also known as GDP, on healthcare, which in relation to other wealthy countries is quite a lot. And so we would assume that this country, the United States, would have better health outcomes than its other wealthy nations that use less GDP for healthcare. But that's not the case, and we see that substantially with the maternal mortality crisis in the United States. And so I wanted to provide you with some data from a book that I read called Policing the Womb. And the author reported that CIA data noted that when we look at maternal safety rates, the US ranks lower than war-torn nations such as Syria and Bosnia. Again, sit with that. So now, I would like to share with you all a video just to put this all again into greater context, giving you some live stories from other women, other Black women who have gone through these experiences, and just again, placing this into the greater context.
Now onto the silent crisis in our nation's maternity wards. African-American mothers dying at a higher rate than any other racial or ethnic group from childbirth-related complications. Families affected by this tragedy share their stories on the day their lives changed forever. Janae Norman has this report.
What was supposed to be the start of a new life turned out to be the end of another. 26-year-old Amber Rose Isaac was preparing to give birth at the height of the coronavirus pandemic in New York City in April when everything changed for her partner Bruce.
And I just remember staring and, looking at her face and seeing how scared she was, and panicking a bit. And so I'm telling her, yeah, we're going home. This is what we prepared for. This is what we were ready for. It's time. And she looked at me and said, yes, all three of us are going home. And that was the last time I seen Amber.
Amber posted on Twitter about, quote, dealing with incompetent doctors. She died 4 days later. Bruce says Amber tried advocating for herself, but doctors just wouldn't listen.
When she voiced her concerns to her OB, she was letting her know, she's not feeling right. She's feeling a lot of discomfort. She's having shortness of breath. And her OB didn't really understand. She was like, oh, well, there are other women who are working while they're pregnant. So that right there just told me she didn't really care about Amber.
In a statement, the hospital spokesperson saying 94% of our deliveries are minority mothers, and Montefiore's maternal mortality rate of 0.01% is lower than both New York City and national averages, adding any maternal death is a tragedy. Amber's story is not uncommon. July 2nd, 26-year-old Sha'Asia Washington died during an emergency C-section. And July 27th, Yolanda Kadima, a doula and mom of 7, died giving birth to twins, also during an emergency C-section. Experts like Professor Deirdre Cooper Owens, who's written about how race and gender impacted American gynecology, say the struggles these women face throughout their pregnancies and childbirth all come down to racism.
You see that class and status tend to matter. The higher up you go, right, the kind of better protected you are. That doesn't exist for Black women because we're all experiencing racism in the same way. So when I walk into the office, nobody knows if I'm married or have a PhD or what my income is. The assumption is I might be lying, maybe I'm promiscuous, maybe I don't eat well. I should still be given fair treatment and equitable treatment by my doctor.
My first pregnancy, my birthing experience was pretty traumatic.
And then he actually punctured my spinal cord. I was temporarily paralyzed.
We were so excited about bringing Jason to this world, and then the last 2 or 3 days of his birthing process was too tragic.
I was bullied and I was abused emotionally and physically, in the sense that consent was not asked for as often as it should have been.
It took me a while to find a provider that I trusted and that respected me.
We lost him due to what is known as HELP syndrome. We found out later on that his death could have been prevented, as well as the traumatic birthing experience that she experienced.
So many Black families with similar stories, and these experiences add to a mistrust between the Black community and the medical community.
So thank you all for listening to that video, and I hope it put more things into context about the real life stories of folks going through this, as I prefaced with the statistics. And so I would be doing an injustice if I didn't talk about medical racism and obstetric violence in the context of this presentation. And so we really want to place this and say that the cause of a lot of this is medical racism and obstetric violence. And so when we're talking about medical racism, we're referring to the discriminatory practices perpetuated against individuals by the healthcare system based on one's race or ethnicity. And so here, this is one example that some of us may know and some may not know, but there's been a common practice in the past and thought process that Black people experience pain differently than white people. That is a prime example of medical racism and how that can perpetuate damage onto Black people and Black women in this case. And when we look at obstetric violence, we're referring to the harm inflicted during or related to pregnancy, childbirth, and the postpartum period. And so a prime example of this would be, for example, a clinician, provider, midwife, doctor, etc., going into a birthing person's room and trying to conduct a procedure without getting their consent, asking them if it's okay for them to proceed with a particular action, whether that is doing a vaginal exam or cervix exam, or making a decision for them based on their assumptions that they think is best for them. Now, when we talk about the maternal mortality crisis in the United States, it's important to note and have a conversation about birthing while being Black in prison. And we'd be doing a disservice if we didn't talk about this. And so I have a few points here that I want to briefly talk about to give you context of what this is like for Black women birthing in prisons. For starters, we're seeing a huge piece of forced sterilization for Black women in prison. Zaire spoke about this earlier, and for those that don't know, sterilization is basically either the removal of one's uterus, which would be a hysterectomy, or a tubal ligation, also known as having one's tubes tied. But this is done forcibly and without the voluntary consent of that person. In prisons, sterilizations are used as a bargaining token for lesser sentences and lesser time in prison for Black women. So you can see how one's autonomy and freedom is taken away in this situation. Now, also in prisons, many women are giving birth in cells alone where they're shackled to their beds during the birthing process. For those that don't know, who haven't seen any videos or mimics of birthing experiences on television, it's quite a process that may take a lot out of someone, right? And so having someone shackled to a bed can not only cause harm to that person, but cause harm to the unborn child. Additionally, prisons are not often a place where we see lots of care facilities for people who are obstetric patients. So we don't really see pre and postnatal care in prisons, and we don't often see healthcare facilities in prisons. Some prisons do have healthcare facilities for people to give birth, but most prisons do not. I also wanted to hone in on a specific act that happened in Florida. And so this act is called the Tammy Jackson Healthy Pregnancies for Incarcerated Women's Act. And this act came about because a mentally disabled woman in Florida gave birth to her child alone in her prison cell. With advocacy from her mother and other Florida legislators, this act came about to protect the rights of incarcerated women. Again, I'd like to note that it doesn't matter that, yes, we do have these acts, but it doesn't guarantee that these women receive adequate care when giving birth in prison. And the last piece, the Protecting the Health and Wellness of Babies and Pregnant Women in Custody Act. Again, this is another act that is used, and the intention of it is to protect the rights and safety of Black women and women overall while they're giving birth in prisons. But there's no guarantee that prison guards will follow these procedures. There's no guarantee that there will be clinical staff at the site to protect the rights and safety of the birthing person as well as their child. And so here I just wanted to provide some quotes just to put it in context from Black women. Two of these quotes I received from a book that I read called Reproductive Justice, Battling Birth While Black. And the other, the middle quote, is from a formerly incarcerated woman who gave birth to her child in prison, the child unfortunately died in prison. So the first quote is from Xanthia, and Xanthia was a minor at the time. And so her quote states, "I had to fight the hospital to get up. I got hit by nurses because I could not lay there and birth my child." The second quote, Ava, like I stated earlier, was a former incarcerated woman. At the time, she was 7 months pregnant and she was arrested at a traffic stop and placed in jail. And she gave birth to her child alone in a jail cell, and her child died. And Ava's quote is, my baby was already laying on my stomach at that point, and she, the nurse, had them clip and cut the umbilical cord and stuff, and there was no medical help. And lastly, Barbara was a older woman. She gave birth at 50, and she described this quote. Barbara stated that one resident took a glove and decided to massage my cervix, a dry glove with no lubrication sticking to my cervix. It was worse than labor, the worst pain. It was like being subhuman. So again, I wanted to place this in the context of those who are in the carceral system and those who are not, just to give you an understanding of these are real life people going through these experiences. And it doesn't matter where you are, what status you have, what education you have, Black women are still dying and experiencing horrendous care while giving birth in this country. And so in the midst of the COVID-19 pandemic that we're in the midst of, still trying to figure out where we're at in this case, I thought it would be important to talk about the effect of COVID-19 on maternal mortality. For starters, telehealth limited in-person care. And so what that meant is lots of women received limited access to health screenings, and the ability to catch any health risk early was quite limited. And so we can definitely see that impacting maternal mortality because women may be going on longer with certain conditions that could be prevented and caught earlier with in-person visits, which was limited during COVID. The second is limited support during labor and also the separation of mom and baby. So the first piece, I want to hone in back on what Paige talked about with doulas. And so during the COVID-19 pandemic, many hospitals put restrictions on how many people could be in the hospital room with the mother at the time. And specifically, doulas were not allowed in many hospitals. In hospitals where doulas were allowed, there were situations where there was a limit to 2 support people. And so for some folks, they would want their partner there or a parent, a mother, a grandmother, an aunt to be there with them. And so the doula would not be there and to support that person. The doula is often there to be that advocacy piece, that person who is trained to support that person with educational, emotional, and physical support. And the latter piece, the separation of mom and baby. Given COVID and the picture that we see on the screen, many pregnant people were forced to wear masks during their birthing process, and their babies were removed from them quicker than normal. And the last piece, the social isolation and economic hardships. We all know that COVID-19 really placed us in a difficult position economically, especially for folks working on working jobs that closed due to the pandemic because of lack of close contact. So job and financial security was limited and put at risk. And then also the social isolation piece. When we talk about pregnant women, we need to talk about postpartum depression, right? And so mental health and mental illness can occur during the pregnancy as well. And so such social isolation causes and exacerbates this issue. And lastly, I wanted to just hone in on some current legislation that's in place trying to mitigate the maternal mortality crisis in the US. Again, like I've stated earlier, we do have acts in place. Does it mean that we're solving the issue just yet? Not as yet, but I do implore you again, like Zaire said earlier, to come to our next session next Monday, 6 to 7:30 p.m. Eastern Time, to learn from actual birth workers and focus the conversation on joy and finding equitable solutions. But for now, here are some legislations. For starters, we have the act where we're extending postpartum Medicaid coverage and it going up to that 12 months, 1 year post giving birth. What I talked about earlier, we really have to consider the care of the mother way beyond that 42-day section. We need to consider it up until year 1 and post to really see what's going on with the mother and the baby. Additionally, doula services being covered in Medicaid coverage. When we talk about financial access, we need to consider Medicaid, but also how can we make sure that people who need a doula can receive it and pay for it? Medicaid, covering these services in Medicaid will create such an optimal and care opportunity for women. Currently, there are only 8 states in the United States that cover doula services via Medicaid. That needs to change. And I stated earlier that Louisiana is the state with the highest maternal mortality rate, and you can guess it, they do not cover Medicaid. They do not cover doula services in Medicaid. And lastly, the Momnibus Act. That is a large act that's been in play and in the works for such a long time. Small progress over and over, but the big goal of it is to create legislation, small acts to help mitigate the maternal mortality crisis in the United States. And so next, I would like to pass it over to Paige to give us a great introduction on our next speaker.
Yes, so next we're going to be hearing from our professor, Latanya Mapp Frett. She is president and CEO of the Global Fund for Women and serves on the board of directors for the Global Fund for Women and Global Fund for Women UK. Previously, she was the executive director of Planned Parenthood Global, the international arm of the Planned Parenthood Federation of America, and she is currently a professor in the Population and Family Health Department at the Mailman School of Public Health, and we are so honored to have you joining us here tonight. So I'm going to pass things over to you.
Listen, it's such a wonderful opportunity to get to sit and listen to your presentations, and some of you know on this call that part of my journey with Mailman to get a class on reproductive justice was a long one, and it took some time to get them to include, although I think tenets of reproductive justice, and we'll talk about that, was included early in the work that Mailman did, and particularly in Pop Fam, to look at how we approach some of the public health issues, to talk specifically about reproductive justice as a framework for addressing issues like the one that you're talking about birth equity, to address maternal mortality rates, particularly in the Black community. And I went even further to call the class, to very much focus it on Black bodies and patriarchal societies, because I think it requires us to really be specific on the solutions to some of the challenges that you've talked about. I'm just going to go, and I apologize, Zaire, because you put together these big slides. So I'm going to just kind of walk through reproductive justice a little bit, and then the primary principles, and then the tenets. Okay. But first, I just want us to understand that reproductive justice is a framework, but it's also a movement and a vision. So when we talk about reproductive justice and how it gets achieved, we look at a world where each person will have the power to make their own informed decisions about their body, their sexuality, and their future, regardless of race, income, and class, sexual orientation, immigration status, and other factors. So the primary principles are the right not to have a child. In 1994, when the group of Black women who coined the phrase reproductive justice came onto the scene, where there was a lot of conversation about contraceptive use and abortion and the right to not have a child, they added that the primary principles for them was also the right to have a child and the right to parent children in safe and healthy environments. So that sort of added this fundamental thing that was happening in the conversation, because those were parts that were very important to the women in the Black community in this country in particular, but around the world. As many of you know, reproductive justice is now a term that's used worldwide, and it didn't get any respect in the US in 1994 until those Black women went into the international setting and found community and solidarity with women from all colors, all races, that were working on these issues, because it also to them was much more than just the conversation about abortion and contraception. And so the tenets, as you see, is the equal access, of course, to safe abortion, affordable contraceptives, comprehensive sex education, and then freedom, of course, from sexual violence. And we include all the things that you've been hearing, some of those quotes in sexual violence. Sister Song Executive Director Monica Simpson puts it plainly: it's about liberation. It's about dismantling systems of oppression that make our lives hard in this country, but also that make it impossible for us to have the access and the choices that we want to have. So that wraps up the entire conversation that we've been having here today. And I did want to talk a little bit, and I'm not sure what the next slide is, Zaire, but I did want to talk a little bit about the difference between reproductive rights and reproductive justice, because reproductive rights is an individual legal approach. It's focused on reproductive self-determination, the rights to sexual reproductive health services, information, and education, as well as the rights to equality and non-discrimination. And that's kind of looped back to what Monica was saying, that this, all of those rights, then you have to have access to them. And much of what we were talking about is unfortunately not having those rights. So reproductive justice is a much more expansive, intersectional, and holistic approach. It's the complete physical, mental, spiritual, political, social, and economic well-being of women and girls based on the achievement, the full achievement and protection of women's human rights. And the reason why I think it's so important for us to understand why a justice framework in this case is going to be important as we try to solve these issues around maternal mortality is that in general, justice frameworks are a way of seeing and acting, right? It's aimed at resisting unfairness, whereas rights in the sort of articulation of rights is not about seeing and acting. It's really a legal process. And so this aim to resist unfairness and inequity is what's going to enhance freedom and possibilities for everyone. And so the way that it applies to birth equity, love that, and how we apply the framework, in my opinion, is that we have to make reproductive justice the goal, right? And then we have to put rights and development then at the core of that goal. But we also, and probably more importantly, have to start think differently. We have to think very differently about how we address these issues. I think Zaire starts off with a history, particularly in this country, when you have a history like the one that she explained, it means that same things that we're using to ensure rights for some people, in particular, the majority in this country, is going to have to be different. You looked at the numbers that I think it was Paige that you put up, you know, or Maya, I'm not sure, but the differences between Latinx women and Asian women in this country is very different from Black women in the country, and that is because of the history. So we're going to address these issues. We're going to have to think differently. We're going to have to reach further than we would for some of the majority communities. And then we're going to have to ensure adequate resources. I mean, I wrote a whole book about, you know, the need to fund feminist organizations, things like doulas, women who are really making the difference in their communities on addressing these issues. We have to put resources there, because that's how we start to tell a new story. And that's how we start to change the things that we saw in the presentations. I love this quote from Loretta: when it comes to reproductive justice, if you start at the pregnancy, you're starting in the wrong place, because it really does start. It's a mindset. It's a mindset of that we're going to change, and then using a framework of rights at the core to be able to start changing that. You really have to look at the woman that's being handcuffed to a bed while she's birthing as a human, if we're going to change this. And that is the hearts and mind piece that we're still struggling with in this country. Because if you don't see her, if you don't see the twins that were, that they were, sorry, at the beginning, when we were talking about the thing when the two girls were
forcibly sterilized. They were all sisters.
Yes, they were forced sterilization of the girls. Thank you. It's getting late. And, you know, if you don't see them as human, if you don't see them as worthy of rights, then it's going to be hard for us to start to change this. So that is the place where reproductive justice starts the conversation, and it extends it far beyond pregnancy and delivery, but into the life of both the mother and the child, right? And so that's what reproductive justice is trying to get at. I just want to end and, you know, quickly thank all of you for the opportunity to be here and to be able to talk about this work. We talk about movements because those are that's the drive, right? That's the mobilization and organizing around how we get at these issues. If there weren't all of these brilliant women, and we can go down the list, and I thought Joya was going to be on this, but, you know, these women who keep the mantle up, who continue to fight the battle, who call people out on even what's happening in the US. I mean, we are one of the few, if probably the only country in this quote unquote industrialized world where maternal mortality rates are going up instead of down, right? So that says something. And then I think the distinction being made on who in this country is experiencing those discrepancies is huge. And it should be talked about, and we have to talk about it, not just in the legal system, but we have to talk about it globally because it's important. So I will end there, Zaire. I don't know if there were other things that you wanted me to talk about, but I think I know we're coming up against time, and I didn't know if you want to leave some opportunity for people to make some chats.
Yes, thank you, Professor, so much for everything you said. And yes, we do want to leave a few minutes for anybody who has any questions for us or Professor Mapp Frett. And even if we don't get to them today, please feel free to share them at our next session on Monday, because then we'll have a bigger audience, a bigger round table where we can direct those questions to more people that are within the work and in the movement right now.
Thank you so much. We did want to share a page where you can scan to find our references to learn more. Paige also dropped in the chat our toolkit, which we'll also be sharing at our Monday event next week. So please feel free to come out. We also have our email addresses on the slide here if you'd like to contact us, learn more about our project and why we decided to go forth with this.
We are so excited again to have you here, and really thank you for joining us tonight.
Thank you all so much. We appreciate you. Thank you. Thank you.